Okay. Good evening, everyone. Welcome to this AHNS sponsored webinar. I'm Ryan Gepford. I'm very happy to be leading or co-directing this discussion with Fumi Okayemi. We and several others were involved in thinking about a topic that would be beneficial for this, and we hope that this will be a practical and fun, helpful seminar. We have some excellent panelists, and I'm going to jump right into this. I have no disclosures or conflicts of interest. So why did we choose this topic? Um, we all know that this tool and this procedure is becoming more popular, and it's one of the specific things in our field that requires dedicated training and credentialing. We thought that this may be helpful for the new fellows that are on the call, for experienced surgeons that may be thinking of adding this tool to their kit, or for trained surgeons who are trying to bring this to their institution that currently does not either have a robotics platform or team, or to bring this specific thing for a head and neck application. There are certainly differences that exist across institutions and hospitals as far as credentialing, case requirements, et cetera. There's certainly differences with the learning curve amongst different surgeons, and there's a number of devices and access to devices, which is different. However, there are lots of similarities. And our goal here today is to generate discussion around these things and hopefully to create clarity and reduce the complexity of this process for those who are present. This will be an interactive panel. We'll discuss a number of things described here. And at the end of this, we're going to have a Q&A. So if you have questions as they come along, please present those to us. We're very fortunate to have three panelists here today. I'm going to go through them. Dr. David Rice is a professor of thoracic surgery, and he is the co-director of the Minimally Invasive New Technology and Oncologic Surgery, or MENTOS team at MD Anderson Cancer Center. They also oversee robotic credentialing in our center. David has a vast experience in surgery, including robotic-assisted thoracic surgery across several devices, has experience working with the SP device, with the FDA, and I'm excited to have you, David. Welcome. Scott Magnuson is a professor of otolaryngology, head and neck surgery at the University of South Florida School of Medicine. He is also the chief medical officer of Advent Health and the Nicholson Center. Many of you may know Scott as he's an expert in our field, especially as it pertains to robotic surgery and as an early adopter of this technology. And Scott, we're very happy that you were able to join us as well. Lastly is Hal McCard. Hal is a counsel at the law firm of Spencer Fane, based in Nashville, Tennessee. He has several decades of experience in the healthcare sector. Hal has held several diverse positions as a general counsel in legal operations, healthcare regulatory compliance, and complex litigation. We are delighted that Hal could join us today and share some insights on this specific topic. He was a late addition to this panel, so we are very, very thankful for that. As I transition to our first topic on credentialing, I'll say that as the fellowship director at MD Anderson, one of the things that's commonly asked of me is just a letter detailing a particular fellow's experience. This is a screenshot I hesitate to share of my own letter that I will often use. Of course, they often want to see case logs and some type of certificate of training. Our panelists may talk about some of this. There are online in-person ones. There's courses that you can attend. The device manufacturer that's most common doesn't provide credentialing or assessments of clinical competence. However, they are involved and support our society-based TORS curriculum for fellows that involves both online didactics as well as a hands-on course that's put on annually. Of course, credentialing at each hospital has different variables, and I've asked David to start this. So, David, I'm going to bring up your slides here. tell me, I'd like to know if you can share what what credentialing looks like at MD Anderson as I pull up your slides. And I'll let you go from there. So if I'm a new fellow and I'm coming to your institution, I'd love if you can use your slides to talk about how that would go about. Thank you.
Well, thanks, Ryan. And for me, it's an honor to be on this webinar today. I'm part of Mintos. I'm one of the directors. Mintos is an entity that's been around at MD Anderson for probably over 15 years now, I would say. And it stands for Minimally Invasive New Technology in Oncologic Surgery. This was actually begun a long time ago when we sort of realized that there was a need to have a body within MD Anderson to kind of oversee the development of the rapidly evolving new technologies that we were seeing, mainly in the minimally invasive space. And so Mintos was born, and for many, many years now has been responsible really for the initial credentialing, well, at least the setting of the thresholds to allow faculty to obtain credentialing through the CCMS. So at MD Anderson, it's sort of a two-step process. One has to be first credentialed by Mintos, or at least approved for credentialing by Mintos. And then once one gets that approval, then that's taken to the credentialing committee of the medical staff, CCMS, to do the actual final credentialing. But then there's a focused professional practice evaluation that continues on after that initial credentialing. So you can go to the next slide, Ryan. So we'll talk briefly about the reviewing the steps for robotic credentialing, what the current available training through Intuitive, which currently is the only FDA robot, at least for general thoracic surgery. I know there are some orthopedic robots. Probably it's the only FDA approved device, I would think, for head and neck surgery as well. Talk a little bit about SimNow training, and then discuss the actual approval process in FPPEs. So this is what the initial Mintos credentialing form looks like. And this is available on our intranet website. So surgeons can go to that website, download this form, understand in detail what the various steps are. But essentially, for a new faculty to have credentials to perform robotic surgery, they need a minimum of 5 proctored procedures. They have to document all of the Intuitive training that they have received. You can see there that there's a form that one fills out for the procedures, who proctored them, when it was. One has to document the various training sessions that one went through. And then that has to be signed off by the department chair that faculty is going to be a member of. So go on to the next slide there, please, Ryan. So in terms of Da Vinci training, it kind of is, it's a little bit different, right, for trainees who have trained through your program and get experience that way versus brand new faculty who say are coming in from somewhere else. But everybody needs to have undergone and shown documented proof that they have received at least the initial TR100 and TR200 training programs by Intuitive. Now, this is probably a little bit different for the SP platform. I know that there's a separate set of online modules, and there's a separate sort of training progression for single port as well. But it would follow the same thing. And in fact, now that breast oncology is going to be using SP, we're now using single port technology. We're probably going to have to revise our credentialing to also reflect SP. We don't have that right now. So once you've done that, then we recently added in a requirement that everybody needs to undergo simulation training. And this took a little bit of time to get all the various departments to agree on the particular simulation tasks and the minimum score, but these are what we ultimately came down with. And so there's 8 different tasks, and you have to have a minimum score of 90% in each of these. There's our small little simulation room there. So once we have documented the various things on that Mintos form, then that is submitted along with a memo from the chair to the credentialing committee of the medical staff, and that meets every other Tuesday, I think. And then the credentialing committee of the medical staff will review it. Next slide. And then this was something that we recently added. Previously, up until last year, every department did this a little bit differently in terms of their FPPE process for robotics. And so what we did this year was we got consensus amongst all departments regarding the wording for this. And this is on the credentialing form that gets sent to CCMS. So the same form that, say, for thoracic surgery, we would be requesting, privileges to perform a mediastinoscopy and lobectomy and esophagectomy. This is at the end of that form. And it assumes that you basically get credentialed for the individual procedures as you would open, but then you also, if you plan to do any of those procedures robotically, then this part needs to be requested. And you'll note there are 3 different areas on this FPPE form. First of all, we want to specify the number of cases that each department require to be proctored. Then we also want to continue to follow the first X number of cases for the first 6 months. And then we also want some sort of continuing review so that, we don't have surgeons who are just doing 2 or 3 cases a year. We want to maintain some sort of minimal number over a 2-year period. And so for thoracic surgery, and every department differs, each department chooses what these X, Y, and Z numbers are. But for thoracic surgery, new faculty must have a minimum of 5 procedures that have been proctored. And then the outcomes of the first 20 procedures are reviewed with their direct supervisor. So that's usually the chair or the quality officer of each department. And then we chose 50 robotic procedures over a 2-year period as a reasonable number to maintain proficiency. It is worthy to note that we have had experience with new faculty who have come from elsewhere, having done robotic procedures elsewhere. They come to MD Anderson and they try to book cases. We've mandated that you cannot book a case, even if you're a brilliant robotic surgeon, you still have to have 5 proctored cases, and those proctored cases cannot be booked under your name. It has to be booked under the proctor's name. So let's we can go on to the next slide then.
I think that was the last one.
So that's pretty much it.
That's very helpful. I can say that in our head and neck surgery department that some of the numbers are the same. We don't do as many robotic surgeries as you all do, so the number of 50 is lower for us, but I think we also mandate 5 proctored cases even for faculty that we hire that are already experienced TORS surgeons. I'm interested in hearing more about the proctoring and how you develop these skills, and that really provides us a nice transition to you, Scott. I know you have a tremendous amount of experience with different devices, training many different surgeons over the years, and I think this was the perfect transition for you to share.
Thank you, Ryan, and thank you, Funmi, for the invitation to participate on tonight's panel. David, I don't know what you and I are doing differently than Hal. Hal looks younger on his Zoom screen today than his picture that was provided by Ryan, and you and I look older. So we'll talk to Hal afterwards. So I was asked to discuss about training. So different than credentialing. Credentialing is done by the hospitals and by medical staff. But training often is not. And so hospitals and medical staff rely on training in order to credential a surgeon. I'll go ahead and share my screen. I have slides here. So to start in the background is going back to 2008, the Bulletin for the American College of Surgeons put out basically an opinion relating to the training in laparoscopic surgery. And I'll let you all read this very strong statement put out by the authors. But basically what they're saying is surgeons, general surgeons, were going to industry-led training courses and spending a day and then going back to their hospitals with a certificate that provided the currency to obtain credentialing in their hospital. And they were finding that there were increased injuries to patients with this type of training. And so they developed a curriculum that has actually an exam in order to know that you've passed the curriculum, which is a two-part exam. There's a cognitive part, a written exam, and then there's a skills exam. And you have to go to these testing sites to have this. And it's so important that it is now required by the American Board of Surgery, this completion of this course, successful completion of not ACLS, ATLS, but also FLS for surgeons to obtain credentialing in their hospital systems for laparoscopic surgery. And so there have been a group of people who have come together to develop a program called the Fundamentals of Robotic Surgery, which is basically the next generation of what FLS includes. And it was a joint educational program that was funded partly by the U.S. Department of Defense and also an unrestricted educational grant from Intuitive Surgical. And it was a multi-specialty proficiency-based curriculum that is agnostic to platforms. It's also agnostic to procedures. So it is not a curriculum to train procedures, same as FLS. You are not trained how to do, you're not showing that you can do a cholecystectomy. You're showing that you can use laparoscopic instruments safely. This program relies on training to be done within residency programs, fellowship programs, et cetera. It included these gentlemen who were the lead of the development of FRS, led by Rick Satava, who's a general surgeon from University of Washington in Seattle. But several of them, not even all of them, are physicians. Roger Smith, for example, is an educator, PhD. And then Vip Patel, who is a leading urologist, probably, I think he's done the most robotic prostatectomies in the world. And so esteemed group of colleagues from multiple specialties. And these were the organizations that were represented in the development of the curriculum, including my society, the American Academy of Otolaryngology, Head and Neck Surgery. This was there were representatives, myself, Greg Weinstein, were representatives to this group in developing the curriculum. And the curriculum was set on benchmarks using the Dreyfus and Dreyfus model so that if masters performed the tasks or the exercises, proficiency is the mean of the experts and competency is one standard deviation below that mean. And this is the publication from 2019, which was the validation of FRS curriculum. And so we incorporate this curriculum in our facility for training. It's the Nicholson Center. As Ryan mentioned, I'm the medical director of the Nicholson Center, which is in Orlando, Florida. And this is the tool that was developed by FRS. This is called the Dome. There are approximately 10 exercises on this dome, and each exercise is performed robotically by the surgeon and then is scored by a layperson. It doesn't have to be a surgeon scoring. And based on the score, we know, based on the scores of the experts, of the masters, we know what a level score for competency is, for example. And so the learner goes through the education process to reach a score where they know that they're using the machine in a safe and efficient way. And so I'm going to go through some of these slides quickly for time, but this is the tool that's used for scoring. It's called a GEARS, Global Evaluative Assessment of Robotic Skills. It's 6 domains with a 5-point Likert scale, so a perfect score of 30. And it's not looking, did you do the procedure correctly? It's looking at depth perception, bimanual dexterity, efficiency, force sensitivity, autonomy, and robotic control. And you can end up with a score after doing that. And a layperson can watch a 5-minute video of the surgeon performing those tasks on that dome, and then you end up with a score. Another scoring system can be done through computer simulation, and this is an example from Mimic. Mimic has now been purchased by another company, but their scoring is all computer simulated, and it's their assessments are in 2 different metric sets. You have a quality and proficiency metric, which is, for example, time to complete exercise, but you also have risk and safety metrics. So instrument collisions, instruments out of view, et cetera, which are very important in terms of safety. And if you take a learner or a group of learners through the FRS curriculum over a 5-day period, what you can see is at day 1, day 3, day 5, with this red line being the competency line, we want to see these learners to be above competency on their average test scores. But we also look at pass-fail, and this is a timed exercise. And so you have a certain amount of time allotted to perform an exercise. And so we look at pass-fails, and we see that learners improve over the 5 days. But also we look at complete or incomplete. So we let them complete the exercise if they can. So even if they're outside the time it takes to that's allotted for passing or failing, we want to know if they're able to complete or not. And so we can see over the time taking the FRS curriculum that they're able, most are able to complete. Using the Mimic scores, we can take initial performance and end performance in day 1, day 5. These are quality and efficiency distribution, and this is risk and safety distribution. We can see at day 1, when they take the score, our 10 learners are on this side of the bell-shaped curve, but on day 5, we've been able to take those learners through the FRS curriculum and move them into the favorable part of the bell-shaped curve, both on quality and efficiency and risk and safety. The other thing that we can do is identify an outlier early on. We can predict that this person here is not going to do so well, and sure enough, at the end, they still didn't make it up to the rest of the group. And so within that 5 days, we identify these outliers and we give them extra work to do during their training, because our goal is to get everybody up into this competency stage of their training, of their work. Does this have an impact? Does this GEARS score have an impact on patient outcomes? And the answer is yes. Khurshid Ghani is a urologist at Ann Arbor, and he did a very excellent study. He was able to obtain community urologists in the state of Michigan to provide a 5-minute video of a patient, and then they used the Blue Cross data of Michigan, insurance data from Blue Cross, and they looked at quartile 1 for the GEARS score versus the highest quartile, quartile 4, and they saw that there were better outcomes in the higher quartile GEARS score surgeons than there were in the lowest quartile. And again, this is not to penalize this lowest quartile and say you cannot do these operations. It's to identify them because they could go to a 1-day course, a 2-day course, for example, to go over the skills where we can find that they're deficient and bring them up into the higher quartile, resulting in better patient care, better patient outcomes. I'm going to stop sharing my screen right there, Ryan, and say that this curriculum is agnostic to platforms, as I said, as well as agnostic to procedures. And so right now in the United States, the only soft tissue platform device is by Intuitive Surgical, and it's the Da Vinci platform. And we know that there are other platforms that will be entering the US market for soft tissue. As David said, there are many other robots, but not in the soft tissue space that we're talking about today. There are hair transplant robots, orthopedic robots, spine robots, et cetera. So this curriculum is specifically for soft tissue surgery and doesn't relate to these other areas of robotic surgery.
Thank you very much. That's a fantastic overview. I appreciate the questions that are being submitted. I'm going to hand over to Funmi, who will take over for the leading this, and then we will transition to questions thereafter.
Thank you, Ryan. Good evening, everyone. Thanks for joining our panel today. I'm going to share my screen. I'm going to go over some important concepts that we rarely talk about, but I think they're very important for robotic surgery. Just as a introduction to what we're going to be talking about, if you could clarify one thing just for the purpose of the audience, Scott, with the training that you described, at what point in training would you recommend people start doing that? From the point of residency, if they're interested in robotic surgery, to when they're in practice and they're trying to imbibe robotic surgery?
Well, as time goes, Funmi, we're having fewer and fewer surgeons in the workforce, out of residency, out of fellowship, who haven't been trained on robotic surgery. So we will at some point get to a point where we don't have surgeons who need to go somewhere to get trained because they didn't get it in their residency or fellowship. And so what residencies and fellowships use as their criteria for training differs as much as what hospitals and medical staff use for credentialing, for privileging of robotic surgery. So I think the efforts of the FRS is to try to standardize the training and to allow for a testing set that is a validated testing set, so you know if a surgeon, a resident, a fellow is competent or not. It has not been incorporated, but like FLS has. So the American Board of Surgery has not adopted this curriculum at this point. Will they? Probably, as they did with FLS. But it's relatively new. As I said, that was 2019, so only 5 years ago that publication to validate that curriculum. That's a non-answer to your question, Funmi. I think there are too many variations. It just depends on where you are.
Mm-hmm. Yes. I think, David, I see you had a question as well. Thank you, Scott. Absolutely.
I did, Scott. Great presentation. I participated on the thoracic side of FRS. So I'm glad to see that it's actually being used. We don't currently use that model at MD Anderson, at least that I'm aware of, but perhaps we should. The nice thing about the intuitive model or simulation, obviously, is that it scores it for you. For the FRS, how do you do the scoring? Is that fairly labor intensive? It looks like you have to watch videos, that kind of stuff.
So we do the scoring in-house. We have an education team that watches the video and scores for the surgeons. There are companies, CSATs is one, where and they were bought in the last few years by J&J. They have a platform where you can upload video and have not only a layperson score, but also subjective feedback from an expert in that area. Not just watching what the score is, but saying, hey, you probably could have done a little bit better on step 3 and 4. So CSATs has that, and there are some hospitals that are connected directly to CSATs. Our hospital system, for example, is one of those. So the Da Vinci machines are connected directly to CSATs, and those videos are automatically uploaded to CSATs. It is voluntary, however. The surgeon does not have to upload those videos. But David, we're doing them in-house. So those learners who come through our facility and take the course, we have our own graders.
Awesome. Thank you for clarifying that. So that's a great way to kind of segue into the next topic, because we're going to be talking about some of the off-label concerns and legal aspects of performing robotic surgery after you've now been credentialed, after you've been trained. So I'm going to go ahead and start sharing this. Okay, so just a brief mention, obviously we'd like to thank the TORS task force, the AHNS TORS task force here, for obviously co-chairing this division for this webinar, and obviously our team as well that's been participating in the TORS webinar series so far. Just as a quick plug here to remember, there is a hands-on course coming up in February 2025. So I am a medical education consultant for Stryker. And obviously today we're going to be talking about a few things that I alluded to already, including looking at the FDA approval for robotic surgery, some of the off-label concerns, and that will obviously show up in the rest of the conversation this evening. Some legal concepts in robotic surgery that we rarely talk about, but are always good to be aware of in the increasing use of robotic surgery. And we'll sort of go over briefly just a case in TORS. So when we look at the FDA approval processes, it's a very, very elaborate process. It takes usually about anywhere from 3 months to 8 months. The FDA shoots for 3 months, but rarely happens in that time period. Usually you go through multiple steps. Obviously, the FDA is trying to oversee the safety, the efficacy, and of course, the safety from a public protection standpoint of any new devices or biologics or consumer products that are introduced. As a specific detail for the Da Vinci platform, which is, as we've alluded to, the most commonly used robotic system, it's usually been approved through the 510(k) pathway. This is basically where you provide pre-market submission for a device that you're bringing into the market, and basically saying that it has about the same level of safety and efficacy compared to another product that's already in the market, which we'll call a predicate. And so you submit this form, and basically you're also going to attest that this new device is not only safe and not only efficient, but the technology is using the same technology as the predicate, or is using a different technology, but that does not question the safety or bring issues of safety or efficacy into light. So the Da Vinci so far has gone through the 510(k) process for approvals. And here I have sort of the history of approvals for FDA for the Da Vinci platforms. The first was in 2000, when the first iteration of the Da Vinci surgical system was approved for laparoscopic surgery. Over the years, it's gone through multiple iterations and different indications for use. So by 2006, we had the S system, and in 2009, the SI was also approved for oropharyngeal surgery. This is going to come into the conversation later because this is currently being decommissioned. You can, service it again through Intuitive. And so most institutions have gone towards the XI, which is part of what we're talking about when we talk about issues of off-label use. So the XI was approved in 2014. It obviously has many advantages compared to the previous platforms. It's easier to dock, faster docking. It's got better automated arm alignment. It also gives you a wider field of vision. And then by 2019, the SP was approved for transoral surgery. And most recently, there's the Da Vinci 5 system, which was just recently approved as well. So this brings us the question of the off-label use we talked about. Because of the myriad of procedures that you can do with robotic surgery now in the different subspecialties, and because of the cost of the platform, many hospitals are having the XI rather than the SP. With the SP, I know you mentioned, David, about how your institution is trying to incorporate this into breast surgery, the SP, which is fantastic, but there are many hospitals are still using mostly the XI because, again, there's a limited number of specialties that can use a high, cost platform. And so that sort of deterred a lot of people from purchasing the SP at that point, which then puts the head and neck surgeon in a conundrum because here, the question is, do you go ahead and use it off label? And what are the legal and credentialing nuances you have to navigate around doing that in your institution? Or do you self-select, or does this really self-select surgeons to say, if I can't use the SP, do I take TORS out of my practice? And then that leads to decelerating skills on a learning curve that's already steep, as Scott already showed us in his presentation. And so when we talk about off-label use, we're looking at a robotic platform that's being used in an anatomical region of subspecialty that's not been FDA approved yet, or a robotic platform that's being used in a specific procedure that's not been approved yet for FDA clearance. Again, the XI has not been FDA approved for oropharyngeal surgery, but there's been many studies that have shown the feasibility of using XI for TORS off label. The question becomes, would they eventually ask for FDA approval for the XI? Probably not, because the SP is already available for oropharyngeal surgery. But it's an interesting question that, again, we'll seek to kind of talk about more in this panel. So this was a paper that looked at transoral robotic surgery. This was the first paper that compared the XI outcomes to the SI outcomes. And this showed that you had improved operating times overall, you had a decreased console time, and you also had significantly decreased blood loss when you looked at using the XI compared to the SI. And the thought process there being with the XI, there was introduction of the Maryland bipolar process, which also helped with coagulation during procedures. Again, there's been a few other studies here between 2019 to 2021, talking again about the XI. And sometimes when you do an FDA approval, it's studies like this that go towards trying to document safety, efficacy for introducing a new platform. But again, with the SP already present, the issue of off-label use is probably going to keep coming up, and something we're going to definitely talk about tonight. So this brings up to the issues of legal concepts in robotic surgery. This is not something that we usually talk about. We all hope we don't have to talk about it for the most part. And that's why we have Hal here tonight to help us talk about this. But for when we look at the medical malpractice landscape, it's been the number of case payments specifically, has actually been declining since 2001. However, malpractice claims in robotic surgery have been on a significant rise. Some papers are quoting as much as 250% rise in claims for robotic surgery. The thought being there's been an explosion in the use of robotic surgery in different specialties, and the demographics also are somewhat changing to an extent from when it was initially adopted in the 2000s, where it was usually for prostate procedures in males. Now it's more including, gynecologic procedures, neurosurgical procedures, cardiac procedures. When we look at the most common claims that have been made for robotic surgery, they usually have fallen into negligent surgery, which tends to be the highest claim numbers here or frequency. There's also issue of misdiagnosis or diagnostic failure in using the robotic platform for the patient. Improper informed consent. We know informed consent has always been something from a patient safety and quality metric evaluation that people have talked about in terms of patient understanding what they're having to go through. But again, when you think about off-label use, which should also come up in question, how are we doing informed consent for this patient when we're having to use off-label? Training deficiencies. And, I'm very grateful that Scott showed us that whole trajectory on how to basically certify your training for robotic surgery. But these are been some of the claims that have come up in lawsuits for robotic surgery, that the surgeon was not adequately trained or they did not adequately select the right patient as a result of poor training, or the credentialing was negligent at that institution. This was a study that looked at basically comparing malpractice claims between 2006 to 2013 to 2014 to 2021. And they showed that over the years, it looks like there's been not only an increase in the number of malpractice claims for robotic surgery overall in the most recent 10 years, but also you see that there's an increase in the number of female plaintiffs, usually again because there's been an increase in the use in the gynecologic field. Most of the verdicts, however, are in favor of the defense most of the time, which are the surgeons. So that's not really changed much over the years. The award amounts are huge, and that's why we say medical malpractice is significantly costly. But when you look at the number of cases in otolaryngology, so far, at least at the time of this publication, there'd only be one case that had been reported. But with increased number of otolaryngology cases, increased number of robotic cases generally, these are things that we wanted to kind of dive into this evening to talk about what are the things that physicians need to be aware of when situations like this happen. Most of the cases that have happened robotic surgery are, some studies quote about 20 to 30% might be in cancer patients, but most of them are not in cancer. They're not cancer-related cases. This was a case, for example, that showed there was concern about malpractice in doing the TORS for transoral robotic UPP. And the concern here was there was too much of the subpalate removed, resulting in speech impairment and regurgitation. The question here becomes, and I think this is where we're going to lean on Hal to let us know, do you have a question in dissecting a case like this? There are many factors you have to look at, many medical records, many correspondence that has to be evaluated to say, is this really a medical malpractice case, or was this a case of a consequence that could have happened, but was informed consent not done in a way that presented it that way versus as a risk? So when we talk about, medical malpractice, it is associated with significant costs. It does foster or drive defensive medicine, which is where we're ordering more tests and ordering more things than we really absolutely need, leading to higher healthcare costs. But could us improving informed consent processes, could standardizing robotic surgery credentialing criteria across institutions, could increasing knowledge of concept and risk mitigation for physicians help us know how to better navigate this field that could become that's becoming more and more of a reality for us. So as a good segue, Hal, I'm going to have you please join our conversation in telling us, from a risk mitigation standpoint, what are some of the things that you'd advise for physicians in terms of the best ways to handle off-label use of robotic surgery? And I would like all the other panelists to also please, weigh in after Hal is kind of giving us his input here.
Yeah, I'd be glad to hear the actual experiences of the doctors as well. There are a number of different participants in the off-label use decision, so it doesn't occur in a vacuum. I mean, you have FDA who says, very clearly, look, our job is just we're going to provide reasonable assurances that this device will work for its intended uses, and so we're going to regulate that, and we're going to require some of these manufacturers to provide education and certain training, but we're not going to supervise how it's done, and we're not going to tell you who's qualified to do it. So they draw a clear line of demarcation in terms of their regulatory authority. Where that ends, the hospitals and the health systems pick up through their credentialing and their privileging processes, making a local determination as to what's going to be appropriate in the facility under surgical privileges and what's not going to be appropriate. I know places that do not permit off-label uses of medical devices, and medications are treated, somewhat differently, but I think the thinking is the same. So I think the first question would be, does the place where, does my institution address this through its medical staff bylaws, which is and rules and regulations, which is the primary legal structure around which most of these decisions are made, ultimately by the board of trustees, but in consultation through the medical staff bylaw process. So the issue of off-label use, I think, is especially a robotic system device, I think is somewhat complicated. It depends on how the institution views that. As far as the legal basis, as far as the legal underpinnings go, off-label uses are considered to be practicing medicine. That's what we want our doctors to do. We want them to use their judgment. We want them to pick the most efficacious means of treatment, whether the FDA has said that this is an approved use or not, may not, ultimately determine whether it's an effective use, and whether in good medical judgment a doctor might not want to use that. an off-label use, so to speak. But generally, those decisions are made from a liability basis under traditional principles of medical judgment and medical malpractice. You know, was the practitioner applying the same or similar knowledge that a practitioner in his community might apply to make the decision whether to use this particular modality in that way, whether it's a drug or whether it's a medical device. So like I say, they're different, you know, obviously different participants in the process, including your risk management processes, your medical staff, and especially chief of surgery or whatever individual is responsible for the ultimate supervision of the surgical department under the bylaws. But that's sort of how the structure, I think, works in coming to make that decision. I mean, as I think it was just Scott or David pointed out, you know, the single port has been approved since, I guess, 2019 for TORS, and your slide certainly, you know, suggests that there may be other alternatives for that, which would be off-label uses. But the FDA, you know, the FDA is kind of agnostic on it in terms of who makes that decision, because the physician makes that decision in the exercise of medical judgment. The other side of that is an often important one to healthcare systems, and that's, can we get paid for it, or are we submitting claims for reimbursement and being able to be compensated for the work that we're doing? That's a different set of circumstances and a different set of questions. So they're really two: the liability issue and then the reimbursement issue, I think, that inform your first question there. And I saw we had a question in the Q&A from Todd regarding informed consent and why does it say robotic assistance, and why do we have that? And I think to answer your question quickly, Todd, I believe that goes to the issue of informed consent, and what we talk about legally in consents is that the patient should be fully informed of all reasonable risks and certainly benefits of the particular procedure. The term robotic assisted surgery is actually an FDA term of art. That's how the FDA refers to these things. It's within a larger umbrella of computer assisted surgical systems, of which robotically assisted surgery is a subset. And so if we want to fully have informed consent, if we want our patient to be informed of the type of procedure they're receiving, we would want to refer to it by the term of art as a robotically assisted surgical procedure. Your second part of your question was, well, what happens if something goes wrong? I mean, what if we get in there and the thing arcs, or, you know, somebody trips over the plug and unplugs it, or, you know, the lights go out and the generator doesn't come on, and we have to do it the old-fashioned way with our non-robotic methods. And I would urge, I think, folks in their review of these informed consent forms to take into account situations that might occur like that, where the procedure might not have to be done robotically, but due to some unanticipated event, we would also disclose to the patient, as part of the information part of the consent, that it may be done by traditional means if we're unable to proceed with the robotic modality. So that's just a suggestion to you as a way that you might want to address that. But I do think the basis of your question is that it lies in informed consent, fully informed consent about the way the procedure will be done, and then uses a term of art that the FDA uses to refer to these procedures. So I think that's probably why that is. But I mean, does that cover some of that for you?
Yes, Hal, that definitely answers the question, because you know, when you were talking about some of the failures or need to try to convert to an open procedure, that's also one of the claims that has come up when you look at the lawsuits. Has been, they were inappropriately counseled, that those will have to be switched to an open procedure, and then that's brought forward as the cause for a lawsuit. So I think your points in terms of the informed consent process, making sure the patients are aware of what's going to happen, and if something changes, what they should be prepared for, anticipate. I think those are all the things that can go towards mitigating risk, like we're talking about.
Hal or Scott, maybe I'd love, since there seem to be a number of questions that we've gotten about this specific question of use of the XI, Specifically, I've had some former fellows or people that I know ask, hey, I'm at X hospital system. We have this Da Vinci device, an XI, or there's several of them, and there's a hesitance to allow these TORS trained surgeons to use this device, even if they have been trained using that. Maybe just some practical thoughts. I know that we've discussed every institution is different, about them advocating for this. Maybe some practical thoughts.
Ryan, my response is the hospital systems that are reluctant to allow their TORS surgeons who only have FDA approval using SI or SP systems, and they don't have either, and they have an XI, and the hospital is reluctant to allow that surgeon to perform, they oftentimes are not a high volume robotic hospital system, and they have significant influence by Intuitive Surgical on what can and cannot be done. And I have successfully helped some surgeons with a letter like you, stating that, in it properly trained, there is no difference in using an SI system or XI system as the operation is performed. The differences have to do with the shape of the instrument or the size of the instrument. And so otherwise the energy is very similar, et cetera. So, it also, I mean, we have a lot of international guests on tonight. We don't just have guests in the US. I look through the list and I see people from the UK. I see people from Asia, Southeast Asia, Australia, and each country has different hurdles to overcome. For example, many of these countries, there's a distributor that organizes the training on the Intuitive. So it's not an Intuitive-led training, but it's the distributor leads the training and is telling hospitals that, these TOR surgeons can't learn on XIs because it's not FDA approved in the US, and where in their own country, it doesn't even matter. So there is a lot of misinformation that is out there regarding platform use. And Hal, I like what you said, that it comes down to the decision of the physician with the support of the institution. When I moved from UAB to Orlando, and I wanted to first use an XI system because the SI happened to not be available that day, I actually went to our chief medical officer for the organization, the top one. We have many, but the top one, requesting permission to use the XI because I didn't want to go ahead and be new to the organization and already cause trouble. So I went straight to the top to get permission to use it, and it was granted. There was no issue. So so I like what you said. It really comes down to the decision of the physician and the support of the organization.
And I think that's true. I mean, we've had off-label uses for as long as we've had regulatory approval for use. Folks, the FDA especially, and within the judgment of that practitioner, that's where I want those decisions being made. I mean, FDA has created certain cases for expanded access for non-approved uses. They're not. I don't think they're very useful for the everyday practitioner. I mean, they cover things like emergency use, which has to be established through a particular decision-making process. And then, if the patient's life is at risk, if there's an immediate need to use the non-approved instrumentality, if it's life-threatening or severe disability can result. So there's an emergency use exception. There's a single patient or small group exception for non-approved uses, where the instrument could be used for a single particular patient with prior IRB approval, and other things. But they're just not. And there's a treatment ID, treatment investigational device use non-approved devices as well. So about 3 or 4. But having said that, they're not very useful to the practitioner. So the way that you approached it, and going up through that medical staff decision-making process is it's laid out in the bylaws, and who has the ultimate, or how are these questions addressed within the institution, I think is very important, and a strategic way to do it and to get what it is that you want out of the process, and being able to demonstrate safety and efficacy and good outcomes as your magnificent training program proved, I think goes a long way to that as well.
David?
Brian, can I
Yes,
just make a comment on that? So, I mean, one of the ways that we advance medicine, obviously, is doing things that haven't been done before. And you pointed out that, many of the FDA approvals are predicated based on studies that use the robot for non-approved indications, right? At Anderson, how we have addressed that is, again, through Mintos, through this new technology sort of consortium, in that, when there's a new procedure that somebody wants to do with the robot, they will present their concepts to the Mintos group. And the Mintos group, will then vet that, see if there's ways that the new procedure can be performed, but performed in a rigorous manner, not necessarily going through the IRB and making a big production out of it, but at least, starting out with, say, overview by experienced multidisciplinary surgeons from other groups, say in cadavers, and then translating that in a very measured way into the operating room with review of results and accountability. And I think that's really important than for the institution, so that we're not just cavalierly going off and having one surgeon X performing some new procedure that they've never done before.
Can you speak to what qualifies, Scott or David, who would qualify as a proctor in your institution? Is it just somebody who's already credentialed? Is there a specific person? How would that work?
In our institution, it is someone who holds privileges in that procedure.
What about if you're a head and neck surgeon and you want to bring this to your institution, but there's only a urologist who's using a robot there?
That actually happened to me in 2012 when I moved to Advent Health. There were no head and neck surgeons performing TORS, and the bylaws that I needed, because I was new, like David pointed out, no matter how much of an expert I was new, and it was required that I have 5 proctored cases, but there was no one there to proctor me. And so in this case, it was waived. They had just a one-time off waiver for my proctoring. So, it could be handled a number of ways. The institution could pay for a proctor to come in. That's not part of their medical staff. Or they may allow a urologist to proctor a head and neck surgeon. I've actually heard of institutions that do allow that. So, yeah, it could be one of 3: waive it, bring someone in, or let someone from another specialty proctor. But again, it comes down to the medical staff bylaws. What are required by the medical staff?
So what I'm hearing is that individuals who are trying to incorporate this should study their bylaws, should get connected with who's making the decisions in their institution, who are the current robotic users, and I think appeal to something that is mutually beneficial, that has patient safety and outcomes in mind.
Yeah, it's there's not one answer. It depends on your institution. And I think I like the Mintos pathway. It's a very formal organization. I think that's very unique. MD Anderson's leading the way with a group like that. I think that's highly unusual. but yet something that other organizations should think of. Because I'm guessing, David, that you have your Mentos committee, I'll call it, is multi-specialty.
Correct. Yeah. Every surgical department has representation on it.
Yes. So I mean, it's a great way to formalize it, and then that's led by surgeons. It's not, you know, most medical staff are not led by surgeons. Their surgeons are too busy to be medical staff officers. To have something like that to as a resource for the medical staff, because in the end it's the medical staff who gives the approval, right? So I think that's a model that others should consider.
I think that also raises a question, and how you might be able to weigh in on this as well. When the different hospitals have the different, and you know, Scott and David, please weigh in on this too. When the hospitals have the different thresholds for number of cases, how does that play into, you know, litigation or lawsuits when that happens? Because sometimes there's that question of comparison. Oh, this place requires you to have 5 cases. This place requires you to have 10 cases. How do you suggest navigating that?
Yeah, it goes to that. A lot of that goes to the point that Scott was making about, you know, there aren't there's no one here to proctor me, you know, or there's no one here to fulfill the training requirements that's specified in the bylaw. So one way to deal with that is by waiving it, you know, as was done in that case. But I'm sure that before the waiver was granted, there was some review where people could be satisfied, the folks reviewing it, that, you know, we're dealing with someone who knows, you know, who knows what he's doing. It's the liability standard is generally, most places, going to be measured against the community, sort of a community standard. You know, what is the, you know, what is the skill of the physician given, you know, the community itself. And so it's going to be a little bit fact sensitive if you're in, you know, the middle of Arkansas out somewhere, you know, in the middle of nowhere, versus if you're in the middle of New York City. So it's, you know, going to be, the answer to that's going to be, I think, is going to vary a little bit in terms of what training is there. Now, I do know that Intuitive does, as we've discussed, you know, provides a level of training. That I would think that something like that would probably be a minimum expectation, because it's online. I mean, it doesn't require, you know, it doesn't require another practitioner to participate or proctor, but the proctoring issues, I think, would be more, as we discussed, pay somebody to come in, have somebody who's there, or waive it would probably be the alternatives there as well.
And Hal, I don't know, I'm sure it's happened, but as a medical expert myself for many defense cases, I've never heard a plaintiff attorney ask like what number of surgeries is this for you? Because if that surgeon holds privileges in that procedure, in that medical staff, in that institution, they've met the local requirements.
Exactly. Yeah, so exactly. And it's
one place only, my hospital only requires 10 per year for TORS, and which is super low. And they made it low because we have a lot of surgeons who are only doing 10 cases a year. But
yours has a robust process to get there. I mean, it really, I mean, the training that you laid out certainly is, from a risk perspective, I think is really superb. Ensuring the folks that are going to be doing those 10 are trying to keep their privileges, their robotic privileges up to meet the 10 threshold. They certainly would have had the benefit of this, of a lot of review and a lot of practice and things.
Sure.
David?
Yeah, and I think it's not just the minimum number to get there, right? It's also this concept of continuing review over time to make sure that you're still practicing, especially early on, your first 6 months, which is why we have that continuing review, where we have even after you have provisional credentials, you still have to account for the outcomes of the first 25 cases in our department. And we strongly recommend also that those cases be videoed, so that if there is a problem, then we can go back and Monday morning quarterback the situation.
Well, I think we're at time. I certainly appreciate the three of you being willing to share your time and expertise. Funmi and I were thrilled that you were available. I hope that this was helpful for those of you who have joined us. If there are questions that are unanswered or you think of other things, you're welcome to email any of us or Funmi and I, and we will get back to you. Funmi, anything to add?
Yes. Thank you, Ryan. I think this has been great. I think most of the time we don't usually get to have a lawyer with us on the panel, so it's been great to have you on here, Hal. And thank you to Scott and David. We really appreciate your expertise in your fields in definitely showing us the way on how to manage credentialing in our institutions and how to make sure that we do what's safe for the patient. Because at the end of the day, that's really what matters. So thank you all, and thanks everyone for participating in the session today.
Wonderful.
Thank
Thank
you.
you all.
Thank you.
Thank you.
Thank you.
Well, David, Scott, thanks a lot. Take care.
Bye.
Thank you.
Bye, Funmi. Talk to you
Bye.
soon.